groups of folks. So some of you aren't going to see anything new. Some of you will see stuff that you taught me, and I appreciate that. And so thank you very much. I'm going to share my screen. And we're going to talk about the mystery of the Blue Highway, engaging community and research. Now, when I've done this talk a couple of times in a couple of places, and I used to always go to that place and take photographs and Google stuff and, you know, try to be local in that community, make it relevant. Until I was told one time that what I was doing was exactly opposite of what I was telling people, which is be present in communities. And I was doing a drive-by, snapping some photos and putting them into my talk. So you're not going to see a lot of photos of Montreal. You're going to see photos of where I grew up and where I did my work in rural Colorado and Kansas, which is where I have spent the last 30 years doing community-based participatory research and practice-based research. With that in mind, the land acknowledgement that I'm going to give relates to the place where I live and work. It's my experience of the land. I grew up in Eastern Colorado, and I want to acknowledge and honor the legacy of Eastern Colorado Indigenous people who cared for the land for centuries, but who are today mostly displaced to other places, but continue to work and care for the land wherever they are. The Pawnee, the Arapaho, the Cheyenne, the Apache, and the Osage. I recognize that colonialism and the oppression of Native people is a current and ongoing process, and I commit to building awareness of our present participation. I want to pay respect to the elders, both in the past and present, and honor with deep gratitude the land of Eastern Colorado and Kansas for all it gives us. I also want to just mention a historic event that helps frame some of the pain and suffering in Eastern Colorado. In the late 19th century, a battalion of soldiers came upon an unarmed village at Sand Creek and massacred 180 indigenous community members, men, women, and children. And I'd like to have just a moment of silence for those who died and recommit to their memory as we think about reconciliation and living peaceably and respectfully. So we're going to talk about the mystery of the Blue Highway today, and we'll talk about what the Blue Highway is. But this is a quote that we've used in our community for a long time. It's inherently improbable that an academic researcher can ask a clinical question that matters to a patient. Now, it's not impossible, doctor, for you to do it. It's just highly improbable that you will do that. So that's sort of one of the first mysteries. Yes, that is in fact the world's largest prairie dog. That's 14 feet tall. It's in Oakley, Kansas on I-70. You can go see it if you want to. This is a postcard from a place where I've driven through 100 times, Last Chance, Colorado. It has Dairy King and a gas station and a house. And it's the confluence of two highways. So what's wrong with our medical research? Inventing a new medicine takes, from the starting point to improving health, takes years. And in fact, Baylis and Boren estimated that it takes 17 years. That's the good news. The bad news is it takes 17 years for just 14% of the discoveries to make it into clinical practice. Now, I'm a family doctor and I look at that and I go, you know what, 14% is about the right number, because some of that stuff is not very good to begin with. But 17 years, who here uses reusable trash bags? Do you have your own trash bags?
Yeah.
Yeah, you would never use a bag from the grocery store, right?
Oh.
Well, you would try not to, but it took about 17 years for that to happen as well. So we're not alone in disseminating and implementing good ideas. It took about 17 years from the first person who said, I'm going to just take my own bag to the grocery store, to now most places you carry your own bags in. So we shouldn't feel too bad. Healthcare is not that far off. There's a lot wrong. The detours, speed traps, roadblocks, I'm carrying on that highway image, limit treatments and discoveries that go from bench to bedside. Oftentimes there's no external validity. Somebody invents something, and we'll talk a little bit about why that is. Ambulatory primary care is diverse. It's not just people with diabetes. It's people with diabetes and COPD and now depression, and they broke their big toe and they come in and you have to deal with all of those things. And the guidelines don't necessarily fit that human. There's a difference between efficacy and effectiveness. Yeah, this was very effective in a controlled environment amongst 10 people with a condition. But when you get out into practice and what we call free range humans, it's different, it's not the same. I like to frame where I come from a little bit. This is the Dust Bowl in the 1930s. This is just a big blow up of dust. You have these, may have had these in the West, not around here probably, but Viv may have seen one of these out in Saskatchewan. And here's a couple of pictures of towns that I work in. This is Eckley, and then this is an old homestead on the eastern plains of Colorado. Lots of things don't get implemented the way we want. O'Connor, the second bullet, reported on the evidence-based clinical practice guidelines for upper respiratory infections, and it was generally unhelpful because only 13% of patients with a URI were actually eligible for use of the guideline. The other 80% didn't meet the criteria for using the guideline. Well, a guideline that only addresses 1 in 10 of my patients isn't very helpful. Oh, this is Oakley. There's the prairie dog, the world's largest prairie dog, and a 6-legged steer. Yeah, there you go. Alive. So that Dust Bowl, that's, yes, in 1930s, but this continues to happen. I've seen these, here it is in 2002, a dust blow up. So this is still part of our culture in rural communities. We have tornadoes as well. I put these in the problems, we were talking about what are the problems with implementing. Some of this is, what are the problems with rural? Frequently, the major questions that need to be answered aren't prioritized by the funders. What's the incremental benefit to lowering blood pressure an additional 10 points by adding another medicine? Okay, they're on 2 medicines. Their blood pressure's dropped 20 points, but it's still 138 to 140 systolic. What's the incremental benefit of adding another medicine and the cost associated with that, compliance and adherence, and their risks? This one takes a minute for people to. Do you have these in?
Out west.
Okay, so these are tumbleweeds. This is my research assistant's house in Sterling, Colorado. She lives on a little cul-de-sac out on the edge of town, and they had a big windstorm, and she got home from work one day, and here was her house covered in tumbleweeds. The police department or the fire department came out and said, Kristen, you're gonna have to remove those. She said, yes, but living in rural Colorado, you drag them to the street and burn them. So you just pull them out and you start a fire and you burn them right there in the street. So yeah, it's rural Colorado. So what are our problems? Well, we've been consistent in our problems, and consistency is only a virtue if you're not a screw up. So, this is a person who's very consistent, but doesn't necessarily hit the bullseye, right? Now, when I first saw this one, I was like, wow, that's cool. Because just hitting the target for me sometimes is important. So what's wrong with our medical research? Well, maybe we just don't ask the right questions or ignore the many ways of knowing. We talked about appreciative inquiry this morning about as a way of knowing. Or we dismiss knowledge we don't like. I think we do that a lot, or don't understand. So perhaps our rigorous academic scientific process is just incomplete. So what are the mysteries? Mystery number one, why can't our best discoveries make their way to practicing clinicians, their exam rooms, and their patients? And number two, why isn't our research relevant to our communities? Anybody know this picture from The Wizard of Oz? This is Dorothy from The Wizard of Oz. It's a big Kansas thing. It's a kind of a famous movie. I don't know. Were you in a different country at that point? You were in Bolivia. They didn't have it. So we talk about the mystery of the Blue Highway, and we'll talk a little bit about what that is. The mystery number three is the mystery of practice-based research, and we'll spend a little time talking about practice-based research, engaging practices. Mystery number four, the mystery of participatory research, engaging community members. So for this, since I'm talking about Colorado and Kansas, I like to talk about the Blue Highway or the Yellow Brick Road, which is the way to the Emerald City, which is, you know, nirvana and heaven and publication in the New England Journal of Medicine, or what's the big journal here?
Well,
The Canadian Journal of Family Practice. Yeah. So let's talk about practice-based research, engaging doctors and nurses and other health professionals and practices in research. And this is a small town in eastern Colorado with the coffee club in the morning. And I used to go to these meetings, to these breakfasts, and hang out and listen to people talking about what was going on in their community. Anybody here know what this is? This is car white box. This is, you can't be here without knowing what a car white box is. So Carr White, the iconoclastic primary care researcher in the 1950s and 60s, published this article in 1961. He used all the data in the United States that was available, and he found that for each month in the community, for every 1,000 people, about 750 of them would report an illness or injury. About 250 of them would go see their primary care doctor. 10 of them would be hospitalized, and 1 of them would be hospitalized in an academic university medical center. Where do we do most of the research in healthcare? In that academic medical center, down the street, down the road, at the big hospital, the academic medical center. That's where almost all the research has been done. And certainly in 1960, that's where it was done. But really, that's where most of it's done. That's where most of the dollars go. This was redone in 2000, and it's very similar. There were some additional places where people could get care, complementary and alternative medicine, hospital clinics, but essentially it's the same. 1,000 people, 750 of them experience an illness or injury in a given month. 250 to 300 seek medical care, 10 get hospitalized, 1 of them gets hospitalized in an academic medical center. So the Blue Highways, we wrote a paper about practice-based research serving as the Blue Highways on the NIH roadmap. So the National Institute of Health in the United States came out with this great plan for disseminating information and knowledge. They said, we're going to have basic science, we're going to translate it T1 into human research, and then we're going to translate it T2 into clinical practice. Boom, we're done, problem solved. 17 years, washed away to 17 months, all good. But they forgot about all those other problems, efficacy and effectiveness, all of the various competing demands that patients have. They've never really thought about how do we translate from clinical practice into actual community practice. So we said, we think there's a missing step here, and it's T3 research, it's translation 3 into actual clinical practice. And so we put in this practice-based research as you go from discovery to humans to bedside, and now from the hospital bedside, we have to translate that into practice in the community. And then we added T4 a few years later to think about how do you prepare the community for these discoveries. So if community members don't understand the word hypertension, all the hypertension guidelines in the world aren't going to help, because you're only going to see the people who come to the practice. So we really need to make sure that the community also has a receptor site. Or is there a problem?
Will you be sharing the slides?
I'm sharing them right now.
I think the answer is
Sure.
no. Yeah, okay.
So here we have the car white box and traditional translational research, T1 and T2 down in the hospital, but we wanted to move it out. So it fits this car white box, the translational roadmap, those blue highways. So back in the day, maps had the interstate system, and then they had the state highways. And the interstate systems, the big fast way to get somewhere, were red. And the state highways and the county bypasses and those were blue on the old maps. So we talk about blue highways being those places outside of the big academic medical centers where science and discovery can still happen as part of practice-based research. And that fits the car white box. We get out into integrated primary care, and we get out into the community with T3 and T4 translational research. But then there's a whole bunch of other things. There's court systems, there's food insecurity, there's education, there's safe housing and human services. Those are all things that impact our patients. And, you know, now we call them social determinants of health. And they don't just sit in one of those car white boxes. They're cross boundaries. They certainly impact in the hospital at the tertiary medical center, but they also are out into the primary care and out into the community. Even amongst people who aren't suffering illness or injury, they have to address the social determinants of health as well. Most academic research down in the lower right-hand corner, practice-based research out in where all the good stuff happens, all the fun stuff. I hope that all of you are doing the fun stuff. This is from Colorado. This is Fremont's Butte. It should probably have a different name because Fremont was a explorer, a white explorer, and not a very nice human, but yet a butte named after him. So we're going to talk about going out into practices. Until you have the courage to lose sight of the shore, you will not know the terror of being lost forever at sea. And that is what it feels like going out into practices. You leave the comfort of the academy and you don't know what's going to happen when you go out to practices. Genius. So practice-based research is essentially a group of clinicians, practices, institutions that want to work together, and they network over time, more than a single study. So there are a lot of places in the United States where they say, oh, we have a practice-based research network. They got funded, they got a grant, they started a network, the grant ended, the network went away. That's not a PBRN. That may have been a nice experience, but that's not a PBRN. It really needs to have a life over the span of more than one study and over time. They come in so many flavors and varieties. PBRNs, I'm writing a paper right now and I'm hoping to call it, if it looks like a duck and it quacks like a duck, it's probably a PBRN. Because there's lots of ways to quack and walk. And there's ones in hospitals, there's ones in clinics, there's ones that are owned by health insurance companies in the United States. There's ones that are owned by hospital systems in Canada. There's ones that are in one community. There's ones that span a province. How about that? We call them states, but I got the province thing. And there's ones that across the nation. In fact, there's ones that are both in the US and Canada that span the border as well. And there's the old school electrical power there on the sticks, you know, the poles. And then there's newfangled ones that are really electronic health records that have high-speed power lines associated with them. They can be individual clinicians. So Dr. Jones in this practice, they can be the whole practice. All the clinicians in practice agree to join. They can be institutions. We've worked with hospice, nursing homes, home health agencies, public health agencies to be part of a particular practice-based research network. So they can mix the old windmill with the new windmill. They have weird and strange governance. Sometimes they have a director, a research director, maybe a network coordinator, communication system, hopefully a newsletter or some sort of form of communication that goes back and forth. I believe strongly they should have a name and a logo and a brand that's cool. There's some cool named PBRNs. Utopian was one of the, I mean, who doesn't want to be in Utopia? Our name was HPRN because I named it before I understood how important a name was. I would call it something else now, but this is the world's largest ball of twine in Esmond, Kansas, in the lower right-hand corner. You can go see that large ball of twine next time you come to the States. How, did you want relevance for all the pictures?
No.
This
We
is
thought
Kansas,
ground
this is my
floor earlier.
experience.
Colorado, Dust Bowl.
Yeah, this is,
Everything is very confusing. It's just a bunch of.
none of it's, yeah, there you go. There
That's
was
what it- yeah.
exactly,
It's
thank
complex
you.
stuff.
Complex.
So complex, probably complex.
So sometimes they have boards of directors or community advisory councils. Ours has a very powerful community advisory councils. We have practice research assistants. And then you have to have all the things that go along with the Yellow Brick Road: brains, heart, courage, and a small canine mascot. I don't know where that came from. I don't know what that is. Oh,
Toto.
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 You mean Toto too, right? Toto. I think there actually in the United States is a Toto net, and it's, I think so. Well, what can you do in a practice-based research? Well, frankly, you can do anything that you can do in any other research center. Anything you can do at the academy, you can do in practice. You can do descriptive studies, cross-sectional descriptive studies. You can do participatory research. One of my senior faculty said, Jack, you can't do participatory research in a PBRN. And we were like, well, PBRNs really are a form of participatory research because they engage the clinicians in all the decision-making of the research. So they are, and I'll show you a little paper we wrote about that. But you can also do quasi-experimental, you can do longitudinal studies, you can do randomized controlled trials. Now, I'm not convinced this randomized controlled trials are the best use of PBRNs. We're in the process of doing one, and it's a lot of work for what we're going to get out of it, I think, but you can do them. Any kind of research can be done in a PBRN. This is immaterial to the talk, but it's just a nice wheat field. This is what I used to do. I used to drive a combine. So we really pushed blue highways on the NIH roadmap to try to get our funders to think beyond just T1 and T2 research, because there was so much missing in the dissemination. And we said PBRNs are perfectly poised to advance the translational research of discovery to better clinical care and access. Okay, that's what you can do, and that's some of the stuff, but what does it really take to have a PBRN? I call it windshield time. You have to drive around, and this is our region in eastern Colorado. It's 30,000 square miles. That's some number of square kilometers. That's a lot. It's 3 hours to the corner, 4 hours to the right, lower right corner. I put in hot tamales and bit of honey because when I was starting the network, we would drive out, meet with practices, and then we'd drink Diet Pepsi and eat bit of honeys on the way home. And then you really need to have an idea. It's hard to start a research network without some sort of idea. So our first idea was there had been a bunch of research about family docs not doing a good job taking care of heart attacks. The research sucked. It was bad research, but it had an agenda. So the New England Journal and JAMA both published articles about it. So I printed off those articles and I took them out to the family doctors and I said, huh? What do you think? And they were like, oh, let's show them. And so our first big project was around heart attacks. And we showed that heart attack care in rural Colorado is complex, but that they were taking excellent care and they were transferring the right patients to the urban. All the other research had deleted all the transferred patients. Well, the transferred patients, older or younger? Younger. Older, people who had a 50% chance of dying from a heart attack, they didn't get transferred. Younger people, so they were making appropriate triage decisions for maximizing the outcomes. But all those people were deleted. So it just looked like rural hospitals, half the people died because it was all 80-year-olds who died from heart attacks. So what else? Well, I've told people to stop building trust. Stop building trust. Stop building trust. Be trustworthy. So what do you need? You need to be trustworthy with your practices. That's just part of it. You have to sort of do cold calls. Sometimes you have to call and meet people you've never met before. I hyperventilate when I think about it because I can remember those phone calls calling practices where I didn't know anybody and I'd be like, do I dial it or do I not dial it? And so however, if you have an eager student, you can make them do it. So you get students to call a cold call because they want what you have, which is a recommendation to medical school or a graduate degree.
Rejection insurance.
You've got to, you have to be willing to get rejected. So, rejection insurance, not everyone's going to love you. Not everyone's going to say yes. So you have to, live with that. Counseling helps. What else does it take? Well, you have to leave your office, get in your car, drive to another office, say hello, take some food. I had candy in here, but I was reminded that the big sugar is causing lots of problems in North America with diabetes. So big sugar, we got to get away. So just take some good food. And really it's around relationship. Make a friend. This is about relationship-based research. So where in the island are your doctors and your practices? I think this is the only picture of Montreal I have in here, but I wanted to have some homage to my local, where I am right now. Is that right? Is this a map of this?
Yes,
This is
it
correct?
is. Correct.
There's 2 Montreals in Canada, like there's 2 Portlands. There's Portland, Maine, and there's Portland, Oregon. And I've had friends who've made plane reservations for the wrong Portland. And they get on the plane and they end up in an opposite side of the
coast,
country. The wrong coast. So, oh, here we go. Practice-based research is community engagement. And we talked about this, and this has got a lot of famous people on it. I think MacAulay's on this. I'm not sure if John is. John, are you on this paper? This really talks about how communities of practice, rural practices of or communities of condition or communities of race, communities of location, all can be part of the concept of participatory research. Well, let's talk about participatory research and the mystery of participatory research. So this harkens back to that quote, it's inherently improbable that a researcher can ask and answer a question that matters to a patient. This is the Lyman Fire Department. I was the medical director for the Lyman Fire Department and ambulance service. My community members, when they saw this picture, they said, this is a great picture because this is the way we feel when you all come out. You have all the right tools. You have the surveys and you have the p-values and you have your statistical methods and you have your IRBs. You have all the, you have the hose, you have the equipment, you have the safety gear. but you really don't know where the fire is in our community. So how can we help you use all that good equipment and point it in the right direction? So participatory research, again, I learned this not at the Dollarama, but from people who work here. So this is not new probably to you, but it's community-based participatory research is a collaboration with those affected. It's participatory, it's cooperative, it's a co-learning. I learn, community learns. We both learn together. It's ground up. It recognizes expert knowledge both in the research team, the medical experts, and the community members. So there are people who say, we don't use the term expert because it creates a hierarchy. Our group embraces the term expert. I'm an expert at survey methodology, but I'm not an expert at living in Sterling, Colorado. You're an expert at living in, you've raised kids, you've gotten them to school, they're doing well. You're an expert at accessing the educational system and where do you get food and how do you thrive in a rural community? It's a participatory in terms of working together and making decisions together. This isn't Jack coming in and being the decider. We decide together. It has community priorities. So there have been projects that we've worked on that I didn't know anything about, but the community said, Jack, we want to study asthma. Go learn about asthma. We have an expectation for you to learn about asthma so that we can learn about asthma. It's really a partnership. It's a relationship-based partnership. Community members bring individual expertise, researchers bring expertise, and that collaboration is synergistic. It's better than either of the groups could do alone. And I would say it matters more. And I think it's more fun. I've done some and I've done some engagement, and it's just more fun. So the sixth mystery. There is nothing like looking if you want to find something. You certainly usually find something if you look, but it is not always quite the something you were after. From Tolkien. So what really happens when you look for something in engagement and practice? So the HPRN, the High Plains Research Network, had a mission statement to provide excellent rural healthcare by translating the best scientific evidence into everyday clinical practice. This is the 16 counties of Eastern Colorado. It's about 30,000 square miles, about 150,000 people. The cool thing about the High Plains is that we have a denominator. We're a geographically based PPRN. So everybody in this network or in this region is part of us. All the clinics, all the small hospitals, all the nursing homes, they're all part of us. And all of them have participated in some form of research. They don't all participate in every research, but they've all participated in some part of our research. Some of them don't know they're part of the research network. They just know us by the project. They don't know High Plains. They, oh, you're the asthma toolkit people. Oh, we love the asthma toolkits. Oh, okay, we get that. The Community Advisory Council came up with a mission statement. Any of you ever do a mission statement with an organization? 6 months, a year to create a mission statement? 18 minutes. 18 minutes, I timed it. The guiding principle of the CAC is to help inform and guide research in real patient experience and assure information garnered returns to and improves the quality of healthcare in individual rural communities. Boom, done. That's what they said. Jack, as long as this is about the communities, we'll show up. This is, we'll help you, but it has to improve our communities. The minute it becomes about you or your promotion or the university, we're done, we're out of here. Here's a list of some of the community members. Many of them have been to NAPCRG. Some of them have been here to NAPCRG. Some of them you may know. Some of them have collaborated with researchers here. And they've pretty much all stayed on board except for Gary and Shirley. Yeah.
Still on board.
So that's a little bit about participatory research, but what's it really take? Well, you're gonna see some similarities, some parallels. It takes windshield time. You need to get out of your academic office and go be in the community. You have to make cold calls. Hey, Gary and Connie Haynes, I've never met you, but I have a proposal for you to be on an advisory group for healthcare research. What? I'm a farmer. What do I have? And come out to our house and tell us what you have in mind. So I went out, we spent an afternoon sitting at the kitchen table, had some iced tea and pie. And they were like, yeah, we love our community. If what you're doing is a way to think about improving the health of our community, we'll show up until, again, it becomes about you, and then we won't show up. You need gas money, you gotta get going. Stop building trust. Be trustworthy. Be trustworthy with community members. If they show up, they have expectations. Teach us about asthma, teach us about colon cancer prevention. They want to know, and they expect us to teach them. They become experts, they share their expertise at how they communicate in the community. Having an eager student helped, made a lot of phone calls, went out with me. We're not bound by historic designations. Maps of Colorado have changed, maps of Canada have changed. We're not bound by professional differences. Doctors and nurses and social workers, things can go together. We're not bound by work and home address. Zip codes should not be a factor in your health outcomes. Well, you need to have a space to meet. So we meet in churches or libraries. We go out there. Sometimes they want to come to town. We've brought them into town and we go to a baseball game or they go shopping, but oftentimes we go out. I get a question about compensation every time about the community members, and we pay them when we are able. So when we can put them into a grant, we do. Not everyone will allow us to pay community members. So sometimes we don't. We certainly try to always reimburse mileage and meal reimbursement. Sometimes we have childcare if we're expecting parents with children. If we ask them to travel, we certainly cover their lodging. And sometimes we've paid for email because people don't necessarily have email. And our goal is to meet them at least halfway, preferably 100%, but certainly it shouldn't cost community members to be part of this. What? I have 5 minutes?
Well, 10 till we're done, but.
Oh, okay. It's only 1:13. What time we?
1:30.
Okay, so that's 20 minutes. Okay, we're moving. And MacAulay says community is always right. This has really annoyed me. Some of you heard this earlier because she said this to our community members in front of them. She said, Jack, community members are always right. So now my community members that I work with always say, Jack and MacAulay. Okay, I'm gonna move. The seventh mystery. What really happens when you do this, when you engage practices in communities? Here's an example. Centers for Disease Control in the United States sent out a grant for colorectal cancer screening. They called for proposals. Our community members said, yeah, we'd like to go after that. It's about rural, it's colorectal cancer screening. They learned all about colon cancer. They read the book Tipping Point. They brainstormed on what to tell folks and how to tell folks. They held quarterly face-to-face meetings and conference calls. We had emails and individual phone calls. And here's what happened first. Here was the name of the study that the CDC said, interventions aimed at increasing colorectal cancer screening among men and women in rural Colorado. That was what they requested from the CDC. That's what we sent to the CDC. That was the name of the study. And our community members were like, do we have to use the word colorectal? Like, I can't really sit at the kitchen table or the grocery store and talk about colorectal. And since there's only one way in, can we just say colon cancer? I was like, oh, okay. And then they were like, what's screening anyway? So they asked this question. I was like, oh, I have a master's in public health. I'm going to teach you about screening. There's primary screening, there's secondary screening, there's tertiary screening. We talked about all that, about 10-minute little mini lecture. It was awesome. Patient raised their hand and said, Jack, you don't really know what screening is, do you? She said, what you're talking about is a test. So if it's a test, can we just call it a test? So they changed the name from colorectal cancer and screening to testing to prevent colon cancer. Very accessible, based on the science, totally changed the construct from screening and early intervention to possibly preventing colon cancer. They came up with the message, colon cancer is the second leading cause of cancer death in the United States. Fact. Colon cancer is preventable. Fact. Testing is worth it. Fact. Talk to your doctor about testing to prevent. They didn't want to come up with what you should do. Should you do sigmoidoscopy, colonoscopy, FOBT? They said, talk to your doctor, build the relationship, move people back into their local practice. They didn't want a 1-800 number, call the American Cancer Society and figure it out with them. Talk to your local clinician. What did they do? Well, they said, here's the way information is shared. Newspapers, advertisements, farm auctions, big deal in rural Colorado, because it's not just a sale, it's a significant event in the life of a community when somebody leaves the farm, either through death or retirement and moving to town. So they created these cards. They didn't want famous people on them. They wanted local people, people that they could relate to. Kenneth and Elias Sermon. This is the farm auction flyer. This is the standard. This is 11 by 17. It's a very fancy thing. It's full of information about farms, machinery, and miscellaneous, and tractors and collectibles. Except each one of these boxes is actually about colon cancer. And it follows those 4 messages. Colon cancer is the second leading cause of cancer death in the United States. Colon cancer is preventable. Testing is where we put out 10,000 of these all over the farms, all over the feed stores and the hardware stores, and people would pick it up, they take it to their truck, and an hour later when they're sitting waiting, they read it and they're, wait, this is not about farming, this is about colon cancer. What? It snuck a medical issue, a healthcare issue into their farming file in their brain, and they could never go back. Now they all talk about colon cancer. We put out 2,000 of these. If you went to your doctor, you'd get a got polyps mug. These are travel mugs. We still see them 10, 15 years later, got polyp. Talk to your doctor. It's sort of the got milk, got polyps. But Mexico, we did it in Spanish, and Mexico didn't have a got milk campaign, so that didn't transliterate. So we had to do polipos prevenga no los tenga. Polyps prevent them, don't have them. The community members recognized that simple transliteration also was not effective. Did it work? Well, 68% of the community members saw the materials. The problem we had is that community members they ruin research because they shared all the materials they got with their family and friends in the control region. So in the control region, 40% of the respondents had seen some of the materials. And we knew that they'd seen the materials because no one else was putting out a got polyps mug. And so there, yeah, I saw the got polyps mug outside of our study region. What else have they done? They said, okay, we did colon cancer. Now let's do asthma. So they did asthma. They all learned about asthma. They created asthma toolkits and a community program. These are local pictures of people. This is a football player from Lyman. We were working with a prominent urban hospital system that is very well known for respiratory disease, and they have their own marketing. And they wanted to produce regular old public health messages. Hey, do you have asthma? You should, check your spirometry and your peak flows and use your inhalers. And our group was like, we want sexy, provocative. We want dark contrast. We want scowling teenagers. Literally, they said, if we're going to use teenagers, they can't be smiling. They have to be scowling. So this is, and they wanted things like no alibi. What does that mean? They said, well, that means there's no reason for you to give up the things you do just because you have asthma. They wanted something called 1 in 6, because 1 in 6 people in Eastern Colorado have asthma. They wanted them in English and Spanish. Here's the volleyball team from Sterling, scowling teenagers, 1 in 6. English and Spanish. They wanted, this is a provocative one. They wanted the word trigger. I was like, I don't know, that's pretty aggressive. And they were like, yeah, it'll get people's attention. 12,000 people in Eastern Colorado have asthma. Here they used Kennedy. He had asthma. So did, who's on the left? Jay. He had asthma. No one in his organization wanted to go on nighttime activities with him because he was coughing all the time because he had asthma. And then the 12,000, very provocative. What's the 12,000? Oh, that's people who have asthma. They also wanted to use dust masks, but they said, hey, do dust masks help? So we did they came to us and they said, you teach us about this. And we came back and said, well, dust masks don't help people with asthma. And they said, we want to use them anyway because they're cool and we can hand them out. And so that little red thing across the front of that says, does not control asthma. Talk to your doctor. So we gave out 10,000 of these as well that say, talk to your doctor, go get your free asthma toolkit. Okay, I'm going to zip through. They've done colon cancer, they've done asthma, they've done mental health, they've done medication for opioid use disorder. Okay, the final mystery in the age of COVID, pandemics along the blue highways. What happens when you really engage practicing doctors and nurses? What happens when you engage the community? Okay, so we're going to talk a little bit about Shakespeare in Love. Anybody seen that movie? It's an old movie, but it's a great one. The theater in Old England has been closed because of the plague. Or in modern times, that great medical discovery just hasn't really worked out in your practice. And over the last 3 years, thanks a lot, COVID, you've kind of gotten in the way of stuff. Very similar to the plague. So Henslow, this is Henslow, making his way from the theater, runs into Fennyman and Lambert, who are writing a play, trying to get it out into the community. This time we take off your boots. Coals straight to your feet. What have I done, Mr. Fennyman? The theaters are closed because of COVID. Oh, that. By the master of the revels. And you can put in any name there you want as who is the master of the revels. There in the lower right-hand corner, you may know who the master of the revels is. Let me explain the theater business to you. The natural condition is one of insurmountable obstacles on the road to imminent disaster. Believe me, to be closed by COVID is a bagatelle in the ups and downs of owning a primary care practice. So what do? Strangely, nothing. It all turns out well. How? I don't know. It's a mystery. So how does it all work out so well when we really engage patients and communities along the blue highways? I don't know. It does. This is from Blue Highways. On the old highway maps of America, the main routes were red and the back roads blue. Now even the colors are changing, but in those brevities, just before dawn and a little after dusk, times neither day nor night, the old roads return to the sky some of its color. Then, in truth, they carry a mysterious cast of blue. And it's that time when the pull of the blue highway is strongest, when the open road is a beckoning, a strangeness, a place where a person can lose themselves. This is a blue highway that I used to drive frequently in eastern Colorado, up against the foothills. I'd like to thank all of you for attending this. And I'd like to thank the team of people who really allowed me to be here, our research team, Linda, Kristen, Jen, Susan, our community advisory council, the docs and nurses of the practices, those 125 clinicians who were eager to work with us sometimes. So, did anybody get my math? Mystery 1, mystery 2, mystery 3, mystery 4, mystery 6, mystery 7. Did anybody notice I missed mystery 5? Well, I did. Y'all flunked. So what's the fifth mystery is really the work that I learned all this from, which was the work in Ganawagi with Anne and Alex and John and the host of folks in Ganawagi and the Children's Diabetes Prevention Program that helped make the work in the Eastern Colorado really flow. So, thank you.
Here, no, stay here. I have time for questions, but I do want to stop sharing.
I always try to leave a little here. I always try to leave as little time as possible because I don't like
And they
questions.
can be, they don't have to be questions, they can be comments. So please feel free to put on your, lots of hands. Put on your mic and shout it out. I don't have time to read your, come here, Jack.
They can see me.
Nobody's asking any questions. Okay, yeah, go for it.
Be part of the audience.
Okay,
You can be part of the audience if you like.
I'll just be here.
Are there any questions or comments?
How about it in the room? You get first crack at it because you're here.
It's really a question, but I'm curious about any of the work that you guys have done, if it's required any kind of action on the part of the clinical site, that if they have to now start to distribute materials or change something in the way they, and how did that go?
So the question is about, did the research require action at the clinical site? And absolutely. So the colon cancer one, all those colon cancer, all the practices had those mugs, boxes of mugs, and you had to go to the clinic to talk to your doctor to get a mug. You had to, so we did training in all the practices around colon cancer. So we trained all the practices on we did pre and post surveys in the practices. The practices were major contributors to that. Same with asthma toolkits. We trained all the practices in the asthma guidelines and gave every practice in Eastern Colorado a brand new spirometer. You want to get practices to participate? Buy them off with a new machine, which then they could use, it was a billable service. So we went from 0 spirometries to thousands of spirometries, and they were all earning money for the practices. And then they also, they came in and we trained them all in 4 on-site trainings in every practice on the asthma guidelines. Our most recent study, actually, which is an unusual one, was around COPD, and we actually enrolled patients at the practice in a in an observational study, but it required consenting. We went to them at the practice. We don't ever expect the practices to consent, people and do the IRB piece, but yes, the practices have been, for the cancer survivorship, the practices had manuals that they got for cancer survivorship, and they would talk, it allowed them a conversation with survivors of cancer to talk about future planning. So the practices have been involved in almost all of these.
Great.
We will have time for those who are here, we'll have an opportunity to continue to ask Jack questions, but I want to thank, just to be respectful of your time, I do want to thank everybody for coming today. It was wonderful to have you. And I wish you a good Friday afternoon. And Jack, I hope that we'll have you back again soon. Is there any comments? No questions or comments in the chat. So thank you so much.
Just gonna say thank you for a great presentation.
Thank you, Alexandra. It was wonderful to have you.
Thank you.
Appreciate that a lot. So
Shall I leave?
you can leave. You won't leave right then, yeah? Because you have to
I'm
do
not
your
going.
work.
I was just grabbing.
Thank you. Thank you for coming. Bye, John. Thanks,
Okay, any
Marianne.
comments or questions from the
See
local?
anyone in San Francisco who will be in San Francisco? Hi,
See you
Marianne.
in San Francisco.
See you, John.
Marianne.
See you later. Take care. Bye-bye.
Thank you very much. It was great.
Thank you.
Can I get you some more water? Did you guys
Okay.
have any other questions? I mean, Yvonne especially be really interested in your perspective as a participatory researcher.
I was curious because in your presentation, like the person driving to all the places to connect the network and the eager student seems to have a very central role, an important role in building the network. So I was wondering, what do you think it takes to have that person to have someone who is interested in taking
Yeah.